interest, but we're going to talk about the thoughts on the ultimate challenge between the bond of the patient with the doctor. And I don't have any financial relationships. I just like to put this up there. So initially, I'm going to try to set the tone through my introduction, and then talk about some themes and questions that we'll try to answer, talk about humanism and the privilege of caring, talk about the idea of being present, called presence, when we're caring for our patients, and talk more about my personal journey and use personal stories as well as patient stories, which are very powerful, and then have conclusions. I want to say that when I talk about physicians and doctor-patient relationships, I really want to make sure everybody understands that I'm really talking about health professionals, not just doctors, although that's my area, but certainly including the nursing professions, the social work profession, all the health professions that touch a patient's life. I did give you a background check on myself, but I just wanted to graphically show you that if we start from the upper left-hand corner, this is the current New York Medical College where I went to medical school. This is Metropolitan Hospital in Manhattan, where I did my medical school clinical work as well as my internship in pediatrics. This is Yale New Haven Hospital in New Haven, Connecticut, where I spent the bulk of my career, over 40 years there, doing training in obstetrics and gynecology and maternal fetal medicine, and then in practice and on the faculty at the Yale School of Medicine. This is a very interesting hospital. This is Oregon Health and Science University. I got a master's degree there in biomedical informatics. And what's interesting, and those of you from the West Coast might have recognized this, you get to this hospital by a tram, which was really fascinating for me because I don't like heights. But I had to get to the hospital daily by taking this tram. This is Mount Sinai Beth Israel Hospital, where I worked after I left Yale. And this is Mount Sinai Hospital, where I spent the last 12 years of my career. And right now I'm a clinical professor at Mount Sinai, although clinically I'm retired from clinical practice. So you may notice that the title of my organization, so to speak, is Maternal. That's sort of a play on words for maternal. It doesn't have an A in it. And maternal concerns my interpretation of the human dimension of healthcare. And it's about the human experience, hope and despair, celebration and sorrow. And by using forms of expression, which you'll hear about, implicit in symbolic language, poetry and verse, song, prayer, and ritual, Maternal shares age-old empathies and lessons to enhance healing in today's complex healthcare environment. Maternal is actually the successor to a program I developed called Hygeia. And Hygeia was a nonprofit organization that I founded in 1995, which, as I mentioned earlier, was focused on helping families endure the tragedies of pregnancy loss. And the purpose of the foundation was to really bring together families from all over the world, a global community that all shared in the same experience. And it was really early in the internet. So it was before Facebook, it was before LinkedIn, and it was an online community of about 25,000 families. So I no longer run that organization, but Maternal is the successor to it. In order to set the tone today, I want to share with you a poem or two. The first poem is called In Passing. It's by Liesl Mueller. Liesl Mueller was a Pulitzer Prize-winning poet who wrote in her collection, Alive Together, this poem, which she wrote on the passing or the death of her husband. How swiftly the strained honey of afternoon light flows into darkness, and the closed bud shrugs off its special mystery in order to break into blossom as if what exists exists so that it can be lost and become precious. This is a poem that I consider a signature poem of my work, and it's entitled Amare. And it was a poem that I wrote for a family whose baby died at 20 weeks, but it was the mother's third pregnancy loss. And I sort of use this as my signature poem for the work that I do. Forlorn with tears and cries am I, to lose you to your death without but even gasp or sigh, save a wisp of angel's breath, the darkest sorrow I have known. Yet your image burnt in my soul is my gift, my grace, and always will I see your face upon the simmer of placid ponds, and in the clouds where sunbeams hide and raindrops form, and I will speak kind words and write of you, and sing in sweet demur in early morning's dew, and in the crown of daffodils which bloom amidst the storms swept across my brow, in every dream in which it seems you come to me, my love forever do I avow. In my writings, I try to put thoughts together that really can comfort. And this is a statement that I wrote in my previously published book. Though our spirits may fade and our viscera bleed, we are enabled by the agents of our humanity, empowered by ancestral songs and promise. So we want to ask the questions today. How can a patient-centric, humanistic approach to the care of all patients promote healing when we cannot cure? And how can we heal when our patients are incurable and are suffering and then die? I want to ask the question, why are we in the health professions? Why are we health professionals? What is our duty to teach, which is what we're striving to do today, and to give a share of our precepts and oral instruction to pupils who have signed the covenant. This is actually not a direct quote, but a paraphrase from some of the works of Hippocrates. And can compassion and empathy be taught and learned? What is our privilege of caring? George Engel, who was both a physician and a psychologist and a philosopher, wrote, "No understand the dimension of being scientific, but to be known and understood is a dimension of caring and being cared for." We want to ask, is there still an art to the medical practice in the 21st century? And what are these barriers that are coming very rapidly? And we want to try to do the most with the least use of technology. Now that's sort of a paradox in what's happening today in medicine, and hopefully we'll clarify that. Sarah Berger, by the way, used this statement in a talk that she gave at Yale. She's a reproductive endocrinologist and has been the chair. She was the chair at Emory University in Atlanta, the chair of OBGYN there, and had held several other chairs. A wonderful, wonderful doctor, as well as a wonderful speaker and ethicist herself. And when she made this statement, I really bonded with her, and had the good fortune to meet with her and actually make a presentation at her institution. So we're going to talk about humanism and the privilege of caring. And humanism is one of those terms that we use a lot, and someone may say to you, gee, you're such a humanistic person, or, I'm glad you're incorporating humanism in your practice. But hopefully we can try to define what humanism is. I've really had a hard time doing that, but I like to try to define it by explaining and trying to use some expressions that might define it. So the dictionary defines humanism as the concept that there's concern for human interests, values, and dignity, which are of the utmost importance to the care of the sick. Dr. Singer and Riff described humanism and mindfulness in this way: through humility and continual self-evaluation, mindful individuals become tacitly aware of their own limitations and continually address these deficiencies through everyday actions with patients, families, and other professionals. It's also been defined, if medicine protects life, literature can interpret it, using humanities. This was a statement about the use of literature in defining humanism. And the professor at Stanford University, this statement I procured quite a few years ago, wrote that there's a need to learn, and I'm very, very interested in teaching these tenets and having students learn these tenets, but there's a need to learn how to teach the important empathetic art skills of medicine. Linda Pellico, who was the director of the nurse practitioner program at the Yale School of Nursing, wrote that it's no longer acceptable to know our own worth, and she wrote about this as a nurse, and not attempt to articulate what it is that we do, see, feel, and provide to our patients, families, and communities. And the last statement is, I implore you, as you progress in your studies, don't ever treat your patients like case numbers, a disease in the need of a cure. They are people who have feelings, loved ones, and aspirations. Become a healer, not a repairman. That was written by Dr. Schultz, who was then the dean of the University of Texas Medical School. So Hippocrates wrote this little snippet: cure sometimes, treat often, but comfort always. It's our role as healthcare professionals to bring comfort and to heal, and from such healing comes self-reward, self-fulfillment, and honor. And if we are surrounded by despair and inequities and have the opportunity to help with their dissolution, it is our obligation to do so. This is something I wrote about the Hippocratic Oath. And I try to, when I speak to our students, I really try to, not in such objective terms, but to talk about this as we who have taken the oath, because we all do take an oath of some point, of some type, when we graduate our health professional schools. We who have taken the oath to practice our sacred profession, and I truly believe that the medical profession is a sacred profession, with an imperative to respect the sanctity of health for all those we treat. We should do this with a sense of high privilege, for they are the flesh and the blood and the souls of all humanity, past, present, and future. And we, by our choice, their guardians. Maimonides, who was a great physician, a philosopher, wrote that my lofty aim is of doing good to thy children, and may I never see in the patient anything but a fellow creature in pain. And that the physician should not treat the disease, but the patient who is suffering from it. And that there should be a change in the clinician's stance from objective detachment to reflective participation, thus infusing care with greater warmth and caring. This was by a physician, Dr. Francis Carrerio. One of my mentors, Dr. Sherwin Newland, who wrote this book, and I put this book here called How We Die, which is not only a book about reflections on life's final chapter, which he calls it in his subtitle, but a wonderful book about life and about the philosophy of death, as well as the ethics. And he wrote this book, and Dr. Newland was a general surgeon at Yale back when I was a resident, and left his surgical practice to write full time. And he has written many, many books. This book won the National Book Award. And he and I were, not only was he a colleague of mine when I was early in practice, but he was also a mentor of mine in some of the writing that I did. And when I wrote my one and only book, not unlike Dr. Newland has written many, he wrote in the foreword this statement, which I think really talks about what it is to be humanistic. The physicians of the Hippocratic era called medicine the art. They knew that the care of their fellows was an act of creativity. They also recognized that each patient and his or her physician form a bond that is unique unto itself. And that bond is the foundation upon which healing takes place. The bond's formation and maintenance is the fundamental aspect of the art, no less a creative act than is healing itself. It goes beyond the notion of mere empathy and sometimes comes very near to being a form of love. It is when we cannot cure that the bond of patient with doctor reaches its ultimate challenge. So thinking about those expressions and those terms, I think it really sets the tone for what it is to be an empathetic, humanistic health professional. It's interesting that I happened to read this morning an article that was an interview by Dr. Robert Wachter, who is the chairman of the Department of Medicine at UCSF, University of California, San Francisco, a very prominent internal medicine physician. And in this, he was talking about artificial intelligence and talking about how it will be used in medicine, but some of it was a little discouraging and some of it was very encouraging. Certainly there are going to be tasks that it'll be able to do. But one of the things that he mentioned in this was the fact that no matter what artificial intelligence and the chat boxes and anything else that is being used to make our patients technologically better in the sense of helping them, it won't replace the empathy and the human touch, and that there'll never be the extinction of the human relationship between doctor and patient. He also emphasized in this article, which was very, very coincidental that I read this morning, but he also emphasized the idea of the physical examination of the patient and how many times the first thing that doctors will do will be to order an X-ray, order an ultrasound, a CAT scan, even before they're examining the patient. And that it's so important to have that human touch to examine the patient, to have the bond there. And it was really an excellent article and really fit into what I'm about to say. What I'm about to say is stated in this paragraph that in the 21st century, despite the exponential availability of new technologies, there exists a paradox that such technologies succeed only for some. We as physicians have been granted by oath and by ethic the privilege to examine and treat, to counsel and advise our fellow human beings while using these technologies. But we must recognize and heal those unspeakable losses evident when medicine and technology can no longer treat and the physician can no longer cure. And these are just examples that I've put together of great technologies that really have helped us scientifically in all aspects of medicine. The first is the ultrasound, which I'm sure many of you, or if not all of you, have seen ultrasound pictures of the fetus and how it's helped us in our field and other fields, but certainly in obstetrics and gynecology. The fetal heart rate monitor, which is ubiquitous, and this just could represent artificial intelligence, but also the electronic medical record. This represents, and Dr. Devadner can empathize with this, the early aspects of in vitro fertilization when there are multiple embryos that were placed in the uterus. This is a quintuplet pregnancy. This just represents DNA and genomics. This represents apoptosis and cancer therapy. This represents mRNA. So we have all these amazing technologies through the years, but we never want to replace that human touch for caring for patients. And hopefully that won't occur in your lifetime. I wanted to also touch on a very important aspect that I'm very interested in, and that's the disparities in care, not only in the United States, disparities in care throughout the world. And in many countries, the United States being one, but globally, the infant mortality rate is judged by is a marker for the overall health of a nation. And if we expand that a little, the perinatal mortality rate, which in our country, in the United States, is about 6 per thousand, being defined as the fetal death rate from 20 weeks to term, is 6 per thousand. If we think about these rates, we can get an estimate of how we compare to the rest of the world as far as our overall health. And there's such disparity. If you look at this map here, this is a map of perinatal deaths, which is, as I mentioned, this is my area of interest. But you can see the blue represents industrialized countries mostly. And that the rate overall in industrialized countries, if we just use that, is about 1.3%. I'm sorry, about 6 per thousand. That's what it ends up. But if we look at the sub-Saharan Africa, and we can look at this peach-colored area, the rate in sub-Saharan Africa isn't 6 per thousand, but it's 1 in 46, or about 2%. And that really shows that there's such disparity that we have to focus not only all the technology and all this individual humanism that we're talking about today, but we must take into consideration the social determinants of health. What are these? These are conditions in which people are born, grow, live, work, and age. Their circumstances shaped by distribution of money, power, and resources at a global, national, and local level. The social determinants of health are mostly responsible for health inequities, the unfair and unavoidable differences in health status seen within and between countries. So when we think about fetal deaths, for example, or stillbirths, and we think about the tragedies of stillbirths, and we think about even 6 per thousand, which in the United States is relatively low compared to sub-Saharan Africa, we have to always think about the individual. And that for that individual, that statistic means nothing. The statistic for them is 100%. So we want to focus not only on the global problems, but we want to make sure that we can individualize it to the best of our abilities, to that one-on-one relationship, so we can hopefully make it a better situation when the death occurs, when the perinatal loss occurs, and adult deaths. We want to be able to take our humanism and extend it to every patient that we see, every patient that we touch. Now, I don't want to forget the art of nursing. And I know there's a nurse in our audience here, and I didn't put this up for you, but I'm glad that you're here. And nursing is an art. And if it's to be an art, it requires an exclusive devotion, as hard a preparation as any painter or sculptor's work. By the way, this is a quotation, a citation from Florence Nightingale, who was considered sort of the forerunner of contemporary nursing. For what is the having to do with dead canvas or dead marble compared to having to do with the living body, the temple of God's Spirit? It is one of the fine arts. I had almost said the finest of fine arts. I use the word nursing for want of a better, It has been limited to signify little more than the administration of medicines and the application of policies. It ought to signify the proper use of fresh air, light, warmth, cleanliness, quiet, and the proper selection and administration of diet, all at the least expense of vital power to the patient. Now, this is obviously written in the spirit that it's written in, and I put this here because it really expresses back in the 19th century how important it is to have this relationship with patients that isn't just quote unquote science, isn't just the administration of medicines, but it's the use of ancillary techniques, such as in her case, fresh air, in our case, empathy. So I want to just bring that to your attention. I also want to talk a little right now about the hospice movement. In recent years, there's been brought to the health professions and the public and an increased awareness to the need for tools to provide compassionate and an appropriate approach to the management of perinatal, childhood, and adult death, the end of life care. And what I have here is, we know that there's so much written. I talked to you about that book, How We Die by Dr. Newland, but here we have two organizations. This is the hospice at the St. Christopher's Hospice in London, which was really the first hospice in the world to an organization that focused on caring for the dying person. And this is in London. And this hospice here is actually in my hometown of Branford, Connecticut. And this was the first hospice in America. And it was founded by Florence Wald, who was a nurse, in 1974. And it was all she was a part of the Yale School of Medicine, and actually the dean of the mental health and psychiatric nursing program at Yale. And the reason I'm just showing this to you is that it really transcends one century to another century, one decade to another decade. We have a movement, for the hospice movement, which is so very important in helping all of our families, even children and adults dying from chronic illnesses, and children dying from the tragedies of leukemia and other childhood illnesses, to be able to bring them together, to give them comfort care, and to give them the care that they need at the end of life. Again, a humanistic, empathetic, compassionate approach to the care of the patient. So we as health professionals must grasp the importance of our presence, our words and our deeds, when our adult and pediatric patients are dying or are incurable, or families are grieving perinatal, infant, childhood, and adult death. Everyone who touches, speaks with, and interacts with the patient, both in the primary and a secondary role, should be aware of what their lifelong influence is on healing for that patient and family. Now, I want to just take a break here and show you this gravestone and tell you a little about it. This gravestone represents, it's in a cemetery in New Haven, Connecticut, St. Bernard Cemetery. And about 15 years ago, a group of parents got together and they said, we don't know where our children are buried. We had stillborn babies at our hospitals in New Haven, both Yale New Haven Hospital and the other hospital, St. Raphael's Hospital. And when they were born, stillborn, they were all buried in mass graves. And we don't have any place to go, and we don't know where they are. We have no place to go and memorialize their lives or their deaths. We have no place to go to pray or put flowers. What should we do? Well, they all got together. They reached out to my organization, the Hygeia Foundation, which, as I mentioned, is no longer, but at the time, we were able to go to the hospital and be able to find out in the cemetery where the remains were buried. We then had the remains exhumed and buried under this gravestone, so they had a place to go. When this was done, there was an article written in our local newspaper, and about this, which was really a very nice, very poignant article about how we were able to identify not specifically each individual remains, but the location of their burial, and be able to put them now to rest in one place. And I was in my office one afternoon, and I get a phone call from someone I did not know. And she introduced herself, and she said, "Dr. Berman, I understand that uh, you were part of this program, and 50 years ago, my son died at Yale New Haven Hospital, and I don't know where he was buried. He was stillborn, and we were able to track down exactly where he was born, and he was placed in this mass burial site." And the reason I bring this up is that the loss of a child, the loss of a pregnancy, the loss of an adult, the memories never fade, they never go away. And this woman had been grieving for 50 years. There was no, and closure is a hard word to describe, but there was no closure for her. And the point of this is that through a families, through a grassroots organization of these families that got together to want to know where their children were, through this, there was power in being able to remember and speak words. And I was able to speak some words, and others were speaking words. And these words are extremely important in helping healing. And it really gave me a very deep insight into the longevity of the grieving process, and also the longevity of memory. So I bring this up today because I really want you to understand that every time you interact with a patient, and it doesn't have to be in a medical setting, it can be in a psychological setting, it can be in any type of setting where you're dealing with a vulnerable patient, every word you speak is going to be important. I truly believe that the health professions rise above other professions. And when I include health professions, as I mentioned earlier, I'm including everyone that has devoted their lives to caring for patients or populations of patients, the ethics of patients, everyone that's in this seminar today, that it's really a privilege. And I like to use this image as an expression of what a privilege it is. And if we think about this, this is I just got this from the internet. It's a picture of a surgeon with the sharpest knife you can find, the scalpel. It's the sharpest knife, and he's taking the scalpel and cutting into the abdomen of a patient. And if you just think about this in a perfunctory way, you say, oh, well, doctors and surgeons do this day in and day out. Well, I try not to think of it that way. And I try to think of it, and I don't do any surgery anymore, but I try to think of it in the terms that we have this privilege to do this surgery, to cure by, in this case, by operating. And with this privilege comes the concept of trust, and that the patient is trusting us, the provider of this surgery, for example, to cut into their abdomen while they're asleep, do the surgery that's necessary. And again, this is all metaphorical. Do the surgery that's necessary and trust that they're going to wake up. And that trust is really hard to generate. And it takes a lot of work to generate trust. But when there's that trusting relationship, and when you have that privilege to do this surgery, this is what makes our professions the greatest professions, and not just from a surgical standpoint. We could think about surgery in the physical sense. We can think about this this privilege of intrusion into the body, or intrusion into the mind, or intrusion into the community as a privilege. And one day I was operating with a student, a medical student at Yale New Haven Hospital, the Yale School of Medicine. And third year medical students, as you might know, third year medical students, it's their first time on the clerkship. And the third year medical students operate usually with an attending and a resident. And I was doing 2 abdominal surgeries, and I was finishing the first surgery, and I was working with my resident and with the medical student. And at the end of the procedure, as is custom, the resident left the room and went to write the orders or get some coffee, and the medical student would follow the resident, and I would stay in the room and wait for the patient to wake up. And I always wanted to do that. And then I would go to see my next patient. Well, on this particular day, that's what happened. And I left the room after the patient awakened to go to talk to my next patient. And when I went to talk with her, I saw that the medical student that I had been working with was speaking with the patient, unbeknownst to me. And she didn't go get coffee, and she didn't follow the resident, but she felt that she wanted to go meet the patient before the surgery. And I went over to her, and I was talking with her, and I recognized my patient was Swedish, and the medical student was Swedish, and they were conversing in Swedish. Now, this was a very unusual circumstance. This medical student really took it her own initiative to go and talk to the patient, to meet her, to make her feel comfortable, to introduce herself, that she was going to be the student that worked with me during her surgery. This engendered in that patient a trust, not only in me, which I had a long relationship with the patient, but that the assistant that's going to be working with me had this relationship with the patient before the surgery. And this may sound sort of like, what's the difference? It really does make a difference. And when we were scrubbing, I was explaining to the patient, to the student, just like I'm explaining to you, that how impressed I was, first of all, that she did that, but also about this whole idea of trust and privilege. So I just anecdotally wanted to let you know that. But that privilege goes along with what our presence is. Our presence, and you hear this a lot recently about being present in the moment, so to speak. But presence, as defined, is the state or fact of existing, occurring, or being present in a place or thing. Now, I think of presence as immersion and confrontation. And the way what I mean by this is, in medicine, there's a team effort in medicine, and more we work in teams, we work in group practices, and we can easily take care of a patient. And if that patient has a complication and we're not, quote unquote, on call the next day, but our partner or the rest of our team is on call, our team could be seeing that patient, taking care of her complications, so to speak. But what I have found is that works from a physical standpoint, because I might be tired, I might need to go somewhere else to go to my office rather than go to the hospital to see that patient. But what I have found is that is not the best approach. And that the best approach is, when you're caring for a patient, when you're taking care of that patient's problem, it's best to immerse yourself and confront the problem head on, rather than avoid it and let somebody else carry it on. It's extremely important to be able to do this. And it takes a lot of effort, and it takes a lot of work. It also takes experience. And that experience has to be taught at the bedside so that your students will be able to sort of model their uh, proposed plans of practice, how they're going to care for patients, and use you as their mentor, their model, their role model, so to speak. And part of this immersion is being able to communicate with our patients and being able to be forthright and honest, yet very sensitive to these very difficult subjects that we encounter, the subjects of death and dying, of palliative care, of complications. Um, we know that we strive for perfection. We always strive for perfection. We always strive for 100% cure. We strive for for successes, but